and so I invited him to kind of lead this discussion on a time of crisis like this. Dr. Aziz, serves on multiple ethic committees. He has just simplified the end-of-life discussion process as a result of his just active problem solving and crisis intervention in this industry that it is just an honor to have him here with us. So Dr. Aziz, I'm just going to let you take on the discussion from here.
Okay, can you hear me?
You can.
Okay, good afternoon. I hope everybody is well and everybody has their mask on. I guess you don't need it at home. As Beza was saying, there's the number of patients and people in general that have had this discussion is very small, and it actually impacts our care and our resources on a daily basis. And now that the virus and the pandemic is here, you can see on the TV all the time the acute shortages in resources. Part of that is because some of the unwanted and non-beneficial treatments are being given to the patients because of nobody has had serious advanced care planning or discussions with them. So you can do a lot in terms of helping your community and your country and even the world by helping yourself and for people that you are near and dear to you, where this may be helpful, and of course in your work, to have patients have early advanced care planning done. And what this will do is it will decrease unwanted and non-beneficial treatments, which includes some of the patients going to the hospital now that don't need to, getting aggressive treatments that they don't need to, being resuscitated when they should not be. And all of this will in turn save resources that they really are needed more in the emergency setting, especially in a pandemic. Those resources are not just monetary, they are staff, they are lots of equipment, including vents and blood and dialysis units and so on, and also the PPE, the protective stuff that we all need for ourselves and the healthcare workers. So this all you can help with by getting advanced care planning done early with patients, and we'll be talking soon as to what type of patients. But first of all, I wanted to start to just sort of ease the mood a little bit here with a video that sets the stage very nicely. It's also something that we all need to be doing right now, as you well know. Okay, so I hope you enjoyed that. The message is pretty clear. We need to stay inside, which is a form of prevention. So advanced care planning actually is also a form of prevention from, again, unwanted and aggressive treatments that are not beneficial to the patient. So why do we get into this? Why are we in this situation of requiring or giving patients treatments that are really not beneficial? So in my career, I've done a lot of just plain pediatrics and ethics work, and then hospice and palliative care work, because I saw that the end of life was not being handled well. And what the technology has done is it has brought us to this stage. So I'd just like to read a case for you from my book, and then we'll go on from there. Okay. So technology has propelled us into the marvel of never imagined, wonderful and amazing, life-saving and life-prolonging treatments. What state of existence these may sometimes leave us is another story. Unfortunately, many a time it is an existence that sustains a very poor quality of life. So here's the case. Take the case of Margie, who at the age of 67, with long-standing diabetes and 2 earlier strokes, was admitted in respiratory failure from severe pneumonia and sepsis. She was aggressively treated with antibiotics and artificial ventilation, unable to be weaned off the respirator. She was moved to a long-term unit, vent unit, on a trach and a vent and a peg in an unconscious state. She remained that way for over 2 months, also receiving dialysis for renal failure at the same time. And this resulted in her developing about 20 skin ulcers. After multiple meetings with the family, and just short of getting a court order to stop life-sustaining treatments, the family finally agreed to take her off the vent and dialysis and let her die in peace. Not quite the peaceful, dignified death that we would hope for. Not to talk about the wasted resources. And I'm not just talking about the monetary, but the time of the physicians, the nurses, the social workers, the multiple consultants, the trips back and forth to the ICU. And all this is because she never really had any advanced care planning done. Nobody sat down with her while she still had capacity to talk about what was a good life for her. So after we have our at the end of the session, I'd like to hear your choices as to what you think would have happened if she had had some advanced care planning done earlier. Okay, so why do advanced care planning? As this case just showed you, it is so that you may ensure a meaningful life, at least as meaningful it is to you at a minimum level, and a good death, and a peaceful death, a peaceful end for yourself, if it is your advanced care planning, or for your patients, and also peace for the family, that the right things are being done according to the wishes of the patient, which again is the best gift that you can give to the family, because they will not have to make those decisions for you. So next we're going to talk about as to what is advanced care planning. Is it, and just to clarify that, advanced care planning is a process that is essential for all adults at any age, regardless of their state of health, whether they are well or ill. It helps them understand and share with family and healthcare workers their personal values, life goals, wishes, and preferences regarding future quality of life and medical care. So the emphasis here is on the quality of life and the goals of care, and not necessarily just the treatments. So research has shown us that patients agree that the advanced care planning can improve multiple outcomes, especially in patients with serious illness. These benefits are as follows: improved quality and length of life in patients with malignancies, increased rates of completion of advanced directives, which reduces stress, anxiety, and depression in the survivors, reduction in hospitalizations at the end of life, increased likelihood that patients will die in their preferred place, and increased use of hospice services, and thus decreasing the use of extra unnecessary resources. So, how to do this advanced care planning in a simplified manner is to use the quality of life and goals of care approach rather than Chinese menu, different treatments, a whole host of treatments, because when you're like I imagine most of you are, you really don't know what you are going to have to deal with near the end of life in terms of treatments. But you can certainly think about what type of quality of life or what you would feel is a meaningful life to you as far as your function goes. So which brings us to the issue of the capacity. So these discussions need to happen now and today while the patient has decision-making capacity, because you may lose that capacity at any moment from any illness, from meningitis, from encephalitis, from severe sepsis, from renal failure, or from trauma. And now we can see that from the pandemic of the COVID, you can get sick very quickly and fast, and then you can lose your ability to make decisions at that time. So the time to dialogue is now, while patients have their wits about them. The goal again is to maintain the patient at a minimum acceptable level of functioning or better, and finding out what the patient envisions that life to be can be achieved by asking simply the three questions, which again address the quality of life. Beza, you want to put on the slide of the three questions? See if it comes on the. Once you do, then I can tell you what the three questions are. So these three questions are to establish what kind of a life is worth living for the patient or for that person. So the first question has to do with your mental functioning or awareness. So the first question is, what is the minimum level of mental functioning or mental awareness that is acceptable to you with the help of life-prolonging treatments, whether they be medicines or machines or artificially provided food and water? The second question is, what is the minimum level of physical functioning that is acceptable to you with the help of life-prolonging treatments? And the third question is, what, if any, life-prolonging treatments are acceptable to you, and if so, for what period of time, so that if we can get you to your minimum levels. So here are the three questions, and I think Beza is going to send you those electronically later. So you see that if we know that, and if the patient's life is being prolonged by any artificial means, and they are able to function at this minimum level that they have defined, then you're doing something good for that patient, and ethically you're doing the right thing for the patient, because you're getting the patient to live the life they want to live. But if you are prolonging a patient's life by artificial means, and it is below their minimum acceptable level that they feel is meaningful life for them, then you're only delaying the inevitable, and in the process probably causing a lot of pain and suffering, not only to the patient, but also to the loved ones. So again, to find out what these levels are, you need to talk to them ahead of time. So one can say, well, as long as the patient has capacity, especially many of these patients with a virus, that they come in the hospital, they still can talk and they still maybe have capacity. What's the hurry in trying to talk ahead of time? And the reason for that is that when you talk to them ahead of time about the goals of care, they're making decisions in a calm, collected, and rational, proactive manner with guidance from you instead of in a crisis-driven manner. So advanced care planning, you want to put the slide up about the ACP, Beza? So, Beza, you have the, okay, go back a little. One slide, previous one. Do you have the previous slide? Okay, all right. So, so advanced care planning, as you can see, is since when you do it ahead of time, and the whole reason, that's why I call it advanced care planning, you want to do it before the patient is getting into a bad state. It is prevention against crisis-driven, desperate, irrational, and emotional and expensive decision making. When one is very sick, when it's very emotional, one can think straight. Family is all emotional. The decisions are made which may not be the right decisions for the patient. So advanced care planning is going to prevent all that. It helps facilitate the discussions about patients' goals, values, and desired outcomes. And I cannot emphasize enough that what we are trying to do with this is to figure out what the goals are, how the patient wants to live, what the patient wants to achieve. And then how they achieve that is what we then do in terms of treatments or plan of care. By thus helping the patients make these decisions, give them reasons why a certain decision may be better than the other, is to help them be at peace that right things are being done for them and for their loved ones. So everybody's at peace that we are doing the right thing. And a lot of these advanced care planning discussions will end up in formulating a document, which what we call is an advanced directive. And the key again here is early and repeated patient and family meetings to get them to think about this and be comfortable about this. And the use of a medical person, a physician, a nurse practitioner, a nurse, a social worker, somebody who's very familiar with different procedures and diseases and this whole process is very helpful so that the family is making decisions based on knowledge and not on some myths and assumptions that are not correct. Okay, so now the question comes up is with the coronavirus and the pandemic as to what is the burden that they're adding to the society right now. So these are challenging times for healthcare systems and raises a lot of ethical issues as well, especially when you start talking about not having enough resources and maybe rationing of resources. So one priority in discussing goals of care in acute life-threatening illness, especially for patients who have chronic life-limiting illnesses, is not a new concept, okay, because we've been trying to do this all along, even before the virus came along. But the needs have totally heightened because of the likelihood of serious illness in older patients happening now with the virus, and therefore increasing the the burden on the resources, because these are just the type of patients with chronic illnesses that you would think would have wanted to forego prolonged life support, and where the quality of life after life support is unacceptable or chance of survival are low. So if we never had these advanced care planning discussions with them, these are the patients that we could have saved a lot of suffering from. So here are the three major reasons for advanced care planning, why the high priority is right now. One is the autonomy of the patient. So if we do this now, we may avoid intensive, life-sustaining treatments where they were unwanted by the patient or where they do not fit in their goals of care. Second reason is that avoiding unwanted and non-beneficial high-intensity treatment at times of stress on the health care and the decreasing capacity. So it will decrease if you don't do unwanted and non-beneficial treatments, it will decrease the stress on the healthcare providers and the health resources. And third is the provision of these resources, of these treatments which are unwanted and non-beneficial. They also put others at risk, the healthcare workers, the family, and other patients. The advanced care plan can even be done by teleconferencing now, while the patients are not acutely ill. So there's ways that you can help them achieve this. So I want to reiterate one more time that providing unwanted, non-beneficial treatments causes increased psychological stress on the family. It is dangerous for healthcare workers, especially during pandemic, and it is a strain on resources. And we mentioned before, machines could be more like vents and dialysis units, on blood products, and the resources of healthcare workers, physicians, nurses, social workers, etc., and a stress and strain on the PPE, the personal protective equipment. So if we did not do the unwanted, where the patient has said he doesn't want to get less aggressive treatments, or where we know that this is not beneficial and we don't do this treatment, it will save you all of this, what we just talked about. There'll be less stress on the family. There'll be less danger to the healthcare workers getting the disease, and there'll be less strain on the resources. Then you can use those resources for other patients where it is more appropriate to do that.
Dr. Aziz, just to stop you there and ask a question about resources, which is one, I think, a huge fear of some family members right now, is that the fear that there's going to be a time where we have to prioritize care in the event of resources being shortaged. So what kind of protocols are in place right now to reassure family members that loved ones would be able to get the kind of care that they wish and aligns with their kind of goals and wishes?
Right. Now, some institutions have their protocols. Right now, I'm also working on a committee to design a triage, what we call a triage system, which only goes into effect when there is a surge of cases and there's a clear need for triaging patients to decide that we only have, let's say we only have one ventilator and we have 3 patients. And how do you decide which patient gets it? These systems are slightly complicated, but they they are supposed to be in a way so that there's a system, a numbering system. There's you do not know the patient's names or their ethnicity or what race they are and what kind of work they did and so on, so that you can be as objective and if you have to make a choice, let's say 1 out of 3 as to who gets that. Our hope is that we will never get there, but we have to be ready and plan and have a plan as to how we're going to address this if one happens to get there. By this process that what we are talking about right now, the advanced care planning, is that we will automatically, if we do this well, and we had um, done this. By the way, we are not only trying to talk about advanced care planning now because we never thought of this before, but these types of patients that are at, say, will get a small benefit or maybe even harm by receiving these treatments have been there with us always, and I can tell you that almost 100%, if not, well, at least 90% of the consults that came to the ethics committee when I was chair had to do with exactly these types of cases, or they all had to do with end-of-life issues, DNR, no DNR, stop life-sustaining treatments, give transplants or not give transplants. So we have been dealing with these issues for a long time. But now the resources are going to go down. We don't have the luxury to continue these treatments ad infinitum or actually a lot of our staff has been under moral distress many a times in the past for giving treatments to patients that we know are not going to be of benefit to them. What that means is that they will not get them what they want in life and will force them to live in a way, maybe on machines sometimes, that they really didn't want. So that's the danger that happens when you don't have these conversations anyway. So in the past, we almost never have gone this close to where we think, oh, we're going to run out of machinery and resources. But now, as you can see, that this can be possible if this pandemic keeps getting worse and we don't take the steps to sort of, as they say, flatten the curve. So, so what I would say in summary is that if you that I hope that you understand what advanced care planning is now in a simplified format. So what I would like you all to do is to do your own first if you have never done this and have the conversation and give this gift to your loved ones about knowing what is important to you and to get you all the treatment that is necessary to try to get you to the level that you feel life is meaningful to you. And if once we know that we cannot help to get you there because of all the comorbidities or problems that you may have, then we know that letting you go in peace and keep you comfortable, that everybody will be at peace and we don't need to do anything unnecessary just to keep you alive, but give you a life that is meaningful. Third thing is that I hope you can guide others, especially your relatives or patients or friends or colleagues, to do their advanced care planning so that they do not get stuck in these awful situations like the patient I showed you. And I think we have a question from one of the participants about their relative that I'll come to address soon. So my thought is that we first pick those patients that are more likely to have problems, which would be older, patients with life-limiting illness, patients in hospice, patients with severe comorbidities like lung disease, COPDs, chronic asthmas, pulmonary fibrosis, pulmonary hypertension, or patients with severe heart disease like heart failure, chronic unrelenting atrial fibrillation, patients on defibrillators, patients with neurologic illnesses like ALS or severe neurologic deficits, patients with liver and kidney failure, especially with end-stage diseases. So if we can do advanced care planning with these patients before they even get into a situation, we would know how they want a situation of virus or a pandemic. We would know how they want to be treated anyway, with or without the virus. And that would be very helpful so that we don't put them through unnecessary suffering. So these types of patients like that I just mentioned, they need to have the advanced care planning and advanced active done even before the virus comes. But urgency, of course, has increased because of the paucity of resources that may happen with the pandemic and the increased need for tackling the virus that is which is generated now by the illness that the virus gives you. Okay, the next thing I just want to touch briefly on is the MOLST form. And just to remind you that the MOLST form is an order sheet. It's an order by a physician, signed by a physician. It may be things like no return to the hospital if they get ill, no artificial nutrition hydration, no blood if they get terribly sick, or no resuscitation. But this is an order by the physician, written by the physician or a nurse practitioner after discussing with the patient or the family as to what their goals in life would be and whether these treatments they're saying don't do are evidently not going to get them the goals that they want. So a MOLST form is not an advance directive, but it is order written by the physician following a discussion with the patient as to what is important to them in life, okay, and with the guidance of the physician.
Dr. Aziz, we have a question here before we move on. Just for everyone who's participating right now, in the interest of time, we've gone a little bit over the 30 minutes mark. We're going to continue the discussion. So if you would like to stay on and continue on with the discussion, you may do so. If you're here for CEUs, we'll be able to give you an hour worth of CE credits for this program. I really want us to continue this conversation because it's very much very important. We have a question, a very good question from Darcy here. How is hospice care being introduced to how is hospice care being introduced to COVID patients who were otherwise not terminal, but now may be ventilated? Are they considered hospice appropriate and care will be covered?
No, patients that are being ventilated are not considered high hospice patients. If that patient is worsening and the ventilator is not going to be able to save them, then the discussion really is in stopping life-sustaining treatments. And those patients will probably, or withdrawing life support, and those patients will probably die in the hospital. The patients that have had COVID and that improve, they generally improve, and they don't get into a life-limiting illness. So I don't think talking about let's put him in hospice is an issue with those patients. Now, once you stop everything, if the patient is going to survive for a small time, then you might say, okay, we're going to only give you comfort care, but I don't think that really happens. If you're going to stop the ventilator, those patients are not making it. Okay, so hospice discussions are not a major part of those who are severely ill. So they're either getting better or they're not. The good news is that the majority of patients that get that are positive for they do fine. So the deaths that you're seeing are in the Maryland, the data was about 3% or more. So that means 90-95% of the patients are going to be okay. So even if you get the COVID, your chances of going through the illness and being okay is 90% or better. Okay.
Dr. Aziz, can you maybe talk about a little bit about like hospice indicators? Because what about what point do we determine that they could possibly be eligible for a hospice? So maybe if you talk about a little about eligibility, that might be able to cover that question.
When a patient has any illness, doesn't have to be COVID, let's just say any illness, where the physician feels that now their lifespan is shortened and probably they will not last more than 6 months, then the patient becomes hospice appropriate. The question we tell the other physicians to think about is that if you will not be surprised if your patient died in the next year, perhaps it's time to get a hospice consultation to see if the patient is appropriate for hospice. But for me to certify somebody that he is appropriate for hospice, I have to feel very strongly by all the criteria for that, whatever illness the patient has, that they're not going to survive 6 months. They're going to die before 6 months. Then they become hospice appropriate. We are talking with COVID, I think what's happening, you're talking about a very severe acute illness. And those patients are generally, those that are dying, they're dying in the hospital. So that question for hospice is not really even arising. Okay, so it's not, it's totally different. But you may have these patients who, let's say, have these chronic illnesses I talked about that might elect not to have life-saving, aggressive treatments because they know that their chances are already very small. So those patients, if they're not in hospice, would probably become hospice appropriate at that time because they're electing not to go for life-saving treatments, but to go for comfort treatments. Then those would become hospice appropriate at that time. But they already have these comorbidities that make them at high risk for dying and suffering from the disease. And I think that but you can see that case that I presented, that if that lady had had a conversation with her family, she would have laid down some criteria which she meant was a meaningful life. And I'm sure that being unconscious and on a ventilator and being resuscitated multiple times was wouldn't have been. So we could have saved her a lot of pain and suffering, and the children wouldn't have had to make any decision because she would have made her own decision as to how she wanted to live. And her treatments could have been stopped long before she could have been sent to hospice and had a safer and a more gentler end. She never was in hospice while she was getting all those treatments. So do you want me to address the question that somebody else had sent about a 88-year-old father?
Right. So how about with someone who's, old, in their 80s, have,
right. So
comorbidities?
Let me read the question for everybody. So this question says that my 88-year-old father is in assisted living, living near my oldest brother. He has heart disease, asthma, often has respiratory issues. A year and a half ago, he spent 3 weeks in ICU with pneumonia and sepsis. I'm concerned if this comes into his facility that he will go quickly and suffer a lot. I'd like to find a way to talk about what his choices might be add this, oops, what his choices might be in advance of that possibility. Okay, so a couple of things the way I would talk to him. One, I would define what the minimum acceptable levels are mentally and physically with the three questions just as we talked about just now. And you can maybe start the conversation and say, you're doing okay, you're doing fairly well, but if things get worse now or in the future, I'd like to know what is important to you so that we would know what kind of treatments to get you and how to manage your illnesses. So, and we would like to know at a minimum level of a mental and physical level that you would say this life is still meaningful to you. So if we are helping prolong it by artificial means, which may be as simple as a medicine that you're giving him, or he might be on a pacemaker or get on a pacemaker or whatever, that life is still meaningful to you as long as you can at a minimum do the following. So he has to define what his minimum levels are mentally and physically. And what I would say at this point is if you go to my blog, it's called You Deserve a Good Death.blogspot.com. It talks about the three questions in more detail, and we can give him examples. So I would usually talk to the patient. I say, okay, let's start from the lowest level, which is that mentally you are unconscious. And the only way you're going to exist and live is if you continue the artificial treatment. And there's no chance you're going to regain consciousness. So most people say, I don't want to live like that. And then I'll go up and improve the mental awareness. Next level would be semi-conscious. You look around, but you have no idea what's going on. Next level might be that you can recognize, you can focus, but not recognize. Next is you can recognize people. Next is you can recognize and communicate with people. And better than that, of course, is that you can have nice conversations, but not make decisions. And better than that is that you have full capacity. In my experience, most people, by the time they say, as long as I can recognize people and have some kind of a communication with them, that's good enough for me. So you would talk to your father, and if he says that's the level, then we keep treating him with whatever is necessary as long as he can do that. Once he goes below that level, then, and there's no chance of returning, then at that point, you can stop all life-prolonging treatments, including artificial feedings, if he ever gets on that. And know that, be at peace that you're not forcing him to live the way he didn't want to. So that's the conversation somebody needs to have with him anyway, virus or no virus. The second thing that you can talk about is this: the last time when you got ill and wasn't the virus, you had an illness that had antibiotics and could be treated. He was in the ICU with pneumonia and sepsis. And that if you get the virus, your chances of making through would be very small. And depending upon what his life and level of function is now, he might say that I'm really ready to go if that happens. I don't want to go through all that. Then he can be made a do not resuscitate and not even go to the hospital, but stay either at home or at the institution with the comfort care under hospice. He might say that I want to go to the hospital and give it a trial of the respirator, and if I am continuing to worsen, then don't continue for weeks, but give it a few days and then stop it. Then one can do it that way. But I think I agree with you that his chances of making it would be very small, especially with his previous experience. And it looks like that the health he's on and all the comorbidities that he has, he's at a very high risk of not making it through that. So the best deal for him is to prevent. If you visit him, keep the distances and all the precautions that we all know need to take. So that's the way I think I would address your dad's illness and his advanced care planning. But
Dr. Aziz,
they,
can you talk
go ahead.
can you talk about right now, and especially in the facilities, um, visitations are limited. So even if people want to talk to their loved ones and get the conversation going, there is the physical barrier of just not being able to leave your own house, given that we're all in practicing social distancing. So how can they initiate that conversation remotely?
You could
Can
probably
advanced care planning be done with telehealth?
yeah, absolutely. So you can do it on actually in the hospitals now we are doing that by telehealth also, where you can use Skype or FaceTime on your phone and so on, or even without the FaceTime, you can at least have a phone conversation. You can say, okay, Dad, we want to talk about this. I know it's a hard subject, but realities of life. You're getting older. You were very sick last time. Now we have a pandemic. We want to have a very clear understanding of what is important to you, how you want to live, and how you don't want to live. And you can also always tell him if he's to go on my blog and sort of just read the blog from the beginning. It'll take about 20 minutes, 30 minutes, and he'll get an idea of what we are talking about. And then you can have a serious conversation with him afterwards, after he's had some of those ideas. Beza had put up some resources here. By the way, those of you who want to make your own directives, you can use multiple forms. You can use the 5 wishes. You can use my form, this format that I'm talking about. I have a form that you can use. Beza, are you going to send them those with that form?
I am.
Okay. It might end up.
Which would you recommend is a good one, a good tool right now to use, a simple tool that would encourage clinicians, but also family members to really initiate this conversation right now? So
I think the simpler ones, the 5 wishes, my form, which is the end of life living plan. So it's a living plan which talks about the minimum mental and physical levels, and talking about your POA, the power of attorney for healthcare decisions, choosing a power of attorney healthcare decisions. It also has at the bottom talks about what do you type place for signatures and what do you do with this form. So after you have talked about these and signed this form, you need to discuss your wishes with your family, friends, your POA, and doctor. Many times you'll be having those discussions with them while you're filling the form. And then you have to take a copy of this form, it's just 1 page, to your doctor and your healthcare facility whenever you visit there. And please carry a card in your pocket that says that you have advanced directives and who your POA is and how to get hold of them with a phone number. Okay, so any of those can be used. Those of you who like to use the internet, you can go to My Directives and make your advanced directives on that. I personally used the Maryland form 15, 20 years ago, and that I found there wasn't enough, and then I added my own part of the 3 questions that I just talked about in addition to that to make it even more complete. My wife used 5 wishes and then used the question that we just talked about, the 3 questions, and added it to that. So you can do it in any way that serves you. You can even write down in your own handwriting or in your own typing on a piece of paper and then sign it and have 2 witnesses sign it. And that is also a legal document. In Maryland, you don't even need a notary public to notarize your signatures. If you wish to go to a lawyer, you can go to a lawyer, have your living will done and POA done. But they usually just talk about those 3 major things that are in the Maryland form. but you tell them about your minimum acceptable goals of living. Again, the emphasis is on goals of care, as the slide shows you, and they will goals of care, where you want to be, what you want to achieve, how you want to live, and they will drive the plan of care, which is what treatments to give to get you there. And if there is nothing that will get you to your minimum goals, again, we're talking about the minimum goals. If they cannot get you to your minimum goals, then we know that now the goal becomes comfort, and we can stop our life prolonging treatments, and we'll all be at peace that we're doing the right thing because we are following your wishes. And that's why it's important to talk to your dad, talk to your grandpa, talk to your mother, talk to your siblings, so you know what their wishes are. Okay?
How about just segueing into now talking about our goals and wishes is great, and having an advance directive is also terrific. But can we talk about the most form, specifically when it has to do with EMTs, where now you have to have, where they're inundated right now with a lot of cases of COVID-19. So as they come into a family's home, they're looking for that order, right? The physician's order.
What Liz is talking about is that do not resuscitate or do not attempt to resuscitate or no CPR order. If a patient has that order, it has to be written on this special form called the MOLST form that is then be available in the patient's home or on the patient's person. Without that form, the EMT by law will resuscitate the patient. So if a patient who's, let's say, end-stage severe illness, multiple organ failure in hospice or not in hospice, and is not expected to survive long, and the physician has agreed that they should be a do not resuscitate in case their heart and lungs fail, then that has to be written on the MOLST form as an order that has to be available to the patient. So if you or your loved one is in that state where you need to be a do not resuscitate, you need to talk to your physician to sign that order. But of course, he's going to ask you why you want it, which is a good thing, because then you can have a discussion with the patient, with your physician, whether this is a good thing or the right thing for the patient or not. Okay. My own father-in-law, we had his do not resuscitate order with him for about a year and a half before he died. So do not resuscitate doesn't mean you're going to stop treatments. All it means is that if you have an arrest, your heart or lungs stop working, that you will not no attempt will be made to get them going again, because we know that either they won't be able to do it, or you will be in such a horrible state that you have decided already with your physician that not resuscitating is the right thing to do. Okay.
Let's talk about helpful phrases. How can we start that conversation, and just if you can walk us through how we can do it.
Well, there are certain, the helpful phrases are, there are many actually, to make the patient more at ease, to make the family feel that you are compassionate, that you are looking for what is in their best interest. And some of the things I use is things that I can see, because when you're giving bad news or you're telling them, let's say you tell them that, okay, no, not resuscitating you is going to be the right thing here. And the patient is, of course, devastated because he thinks you're you've given up on them. So you can say things like, I can see this is not what you were hoping for, but this is the facts, and we don't want to cause you more suffering, and that's why these decisions are being made. You can say things like, I wish I had better news for you, but right now things looks like your lifespan is short, and I advise that you get into hospice that can help you lead a good life or whatever life you have. You can also say things like, I can only imagine how this feels to you, or appreciate that you do or don't want to know what to expect. Some people don't want to know what to expect, and then you can say that. You can say things like, I'm worried for you or your wellness, your health. I wish I could snap and make it all go away. I don't know what to say, but I'm here with you for as long as it takes, and I'll be here, never abandon you. We'll help take care of you. And you can ask things about what are you hoping for to get out of here, because the hope changes. Initially, we're looking for a cure, then we are looking for longer life, then we are looking for less pain, then we are looking for maybe more, more time with our loved one, then we are looking for a gentle end. So you can always are asking for patients for what they're hoping for, and see if there's a way that you can get them what they might be hoping for. And we say, okay, let's talk about the goal that to be achieved, and see if we can get there. So these are just some of the phrases that we can use in talking to the patient. Are there any other questions? Are this making sense to you all? And from the resources that Beza put up, I really strongly recommend. It's not going to cost you anything to please read the blog, and it'll tell you very nicely again how to go about this, because it may be hard to remember everything. And if you are really excited, you're welcome to the book, which is Courageous Conversations on Dying, The Gift of Palliative Care, which is on Amazon. And there are many other, some of the places listed here. You can go there and get more information. Beza, did you get the data as to how many people have their own advanced drugs?
So we're gonna take a poll right now to see how many of you actually have your advanced directives. You're not obligated to answer these questions, but it would be helpful to know. I'm gonna open up the poll right now. You should see it on the right side of, all right. So responses are coming in.
So we have 44 total attendees?
We had initially 58.
80? Oh.
58.
Okay. So we missed the opportunity to ask everybody.
Mm-hmm. Gonna give you a few seconds here.
What's interesting is that the experience from the hospitals, when I do these consults at the hospital, and I've personally done this was a few years ago, and only about 30% patients had an advanced directive, and these prolonged discussions with family were even less. Many times, family knew that they had an advanced directive, but didn't know what it said. They didn't have any discussions, and so on. The important thing really is the conversation. So even if you don't feel like writing anything down, by the way, what you write down today, you can change tomorrow. So it's not etched in stone. So you change your mind, you can change your document. But even if you don't feel like writing anything down, just sit down and have a conversation about what life means to you, what's a good life, what's a quality of life at a minimum. Just having that conversation sometimes is very helpful in the decision making to the family and the physician, because people will remember things you say even if you didn't write them down, and that can help guide them in decision making if they have to make your decisions. So right now that we all have our capacity to make decisions, it's the time to have the conversation.
So we have 16%, 16 people who have completed theirs, and 16 people
16.
said they have 16, 1/6.
Okay.
Percent, 16 people said that they have completed their advanced directives. 13 said no. So hopefully the 13 people, this webinar encourages you to go home, and even if you don't complete a form, that you are having the discussion or appointing
Yes,
healthcare
yes.
agents.
So you can see that, most of us here and most of you there are connected with healthcare one way or another, and it's about 50% in this small sample, and the general public is even lower. But every time we have to talk about treatments in the hospital, I can tell you, it all boils down to sooner or later people asking, what is the patient's wishes, what does the patient want, and why does he want that? So it all comes back to advanced care planning all the time. So please try to do your own first if possible, and if not, at least do it with your relatives and patients that are at high risk, because you'll save a lot of grief to them and to yourselves. Any other questions?
Um, so just before I go on to, we do have one question. I do want to thank you. It is 4 o'clock now, and a little bit over, you're 2 minutes over. I encourage you to complete a evaluation form, which my colleague Meghna is sharing in the chat box right now. Stay You can stay on and ask questions or continue the conversation. We'll be here for about another 10 minutes or so. Thank you so much for joining us, and we hope you stay safe and well, and that we can see you soon.
And I do want to say, if anybody wants to call me directly, email me, whatever, you can email me. If you have a personal question or you need to clarify something, or if there's any way I can help you with that, I'll be happy to. Okay?
And we'll share all resources that were discussed today in the follow-up email, including the PowerPoint presentations, any links to Dr. Aziz's blog, as well as his book, which currently has sold out on Amazon. But I'm sure we'll fix that soon. So we do have one question here, Dr. Aziz. How can we change the culture at assisted living facilities to make do not resuscitate the default and full code the exception?
Oh, very good question. That's that in one of the hospitals when we first started doing this DNRA stuff, was that at one of the hospitals, very progressive hospital, their default was exactly that the physician had to write resuscitate, otherwise the patient was actually every patient had to have a notation to say whether the patient is a resuscitate or not resuscitate. It wasn't like, oh, if nothing is written, you resuscitate the patient. The patient had. So that forced the patient to have a discussion with the family. So that was one way to do that. So one way would be to not to, instead of a default, to say that you mandate that every patient has to be written down full code or no code or whatever, which following our discussion with the family. The other thing is to, of course, have this advanced care planning done well with all of their patients. And I'm actually working with some of the long-term facilities now on that to see how to get this done on a broader base with the advanced care facilities. But I don't have a easy answer for you. I don't know if they can make a default that everybody is a no code just because you're in a long-term facility, or some of those patients are. I think you'll have a riot on your hands. I don't think that can be done as a default at this point. Okay.
Any other questions?
We can do it as a default in hospice where the patients are expected to die within 6 months. Even we have a few patients there that want to be resuscitated. So that's a very tough thing. Okay. Any other questions?
I think that's it. So Dr. Aziz, thank you so much for doing this. It's always a pleasure to have you doing a presentation for the Center for Learning. Thank you so much for joining us. I hope this was helpful in the midst of this pandemic and craziness. I hope this was something that gives you some sort of resource to help not only your patients and clients, but also your loved ones. And so if you take away anything from today, complete your own advance directives, talk about your goals and wishes with your loved ones, and use us as a resource. We are going to have Montgomery Hospice has a page dedicated to advanced care planning and resources in multiple languages there. So we encourage you to use all the resources you have at your disposal to get through these rough times. So thank you so much. Please complete the evaluation form. Your feedbacks are very, very important to us. We actually do read each and every one of your evaluations to help us improve our programs. This program does count as an elective towards Montgomery Hospice's Certificate in End-of-Life Care program. If you're not familiar with it, with the Certificate in End-of-Life program, it is a very unique program created for healthcare professionals who wish to gain a deeper understanding about end-of-life care and palliative care as a whole. Currently have over 250 healthcare professionals pursuing the program. And so showing interest and enlisting in the program is as simple as just letting us know that you're interested, and we'll be able to add you to our list, and you'll be able to get all the perks of having an access to unique programs like this one, as well as our recordings of previous webinars. So if you have any questions, my colleague Alejandra just shared a page to the Certificate in End-of-Life Care right now. Just click on it, and you can sign up for the certificate as well. So without further ado, I'm just gonna let you all go, and I hope you have a wonderful day. Thank you so much for joining us. Bye.
Thank you. So, Bez, are you still there?